This is Pat Walter from the Surface Hippie website, and I'm interviewing Dr. Brooks from the Cleveland Clinic today, and we're at the beautiful Camelback Resort in Arizona. Hi, Dr. Brooks.
Hey, Pat. It's great to be here, and as always, you have a great website.
Thank you. For the new patients that haven't seen your old video, let's do just a little bit of a review. What device do you normally use in hip resurfacing?
I've only ever used the BHR for hip resurfacing. That's the Birmingham hip resurfacing from Smith & Nephew. It's been around the longest. It has the most data. I was trained in it in England, in Birmingham. It seems to make a lot of sense, and I like doing it.
And about how many have you done to date?
In a few days, I'm going to reach a personal milestone of 1,000 BHRs, and that's a lot. I just started in September of 2006. It was approved by the FDA in 2006, and I got on with getting trained, and I've been doing them a lot.
That's fantastic. That's what we want. Dedicated pro hip resurfacing surgeons that are very experienced. Just quickly, could you tell a patient, who are the best candidates?
No question that the best candidates are young active patients, generally males, because we've learned over the years that size matters, that larger patients do better than smaller ones, and just the way humans are, males tend to be larger. Having said that, a tall or large boned woman will do the same as a similar sized man and better than a small man. There are some other gender differences, but size turns out to be one of the most important ones. So if you're an elderly patient who really doesn't have any activity in mind, I don't think you'd experience the benefits from resurfacing, and you're taking unnecessary risks, so I would just have a total hip replacement. But if you're young, you're active, if you think you might outlast a total hip replacement yourself and need it to be revised, you're an ideal candidate for at least considering a resurfacing, because the revision of a resurfacing, if you ever need one, is not a big deal. It's like just the lower half of a total hip replacement in many cases, which is the easy half. But the revision of the lower half of a total hip replacement, that's what you start with, that can be quite a big deal.
And could you just summarize the advantages of hip resurfacing versus a total hip replacement?
Sure. The way I look at it sometimes is appalling for people to hear me say this, is that resurfacing is like putting on a hat, and a total hip replacement is more like cutting off your head. And that's really what it is. If you have a resurfacing, you're just dealing with the damage you have. You have an arthritic hip, you've lost the cartilage surface, it's rough, it hurts, it's not round anymore. And so resurfacing makes all the sense in the world. You just put a new surface on, and you give up very little. You give up maybe just a few millimeters of bone on the upper femur, and that's generally not the normal shape anyway. But with a hip replacement, like, you cut off the head of the femur, you cut it off, and with that you lose 3 or 4 inches of your upper femur, and the device is a total hip stem that goes down inside your femur, and through its angle, it just puts the center of rotation back where it was a minute ago before you cut it off. It has never made sense to doctors, but it certainly works, and I do it myself all the time. It's a very, very, very effective operation, but you're giving up a lot of bone, and with that you're also changing the mechanics of your upper femur, so that instead of your body weight going on the top of your femur where it always has and stimulating strong bone in the upper femur, you now have a thick stem down inside your femur for 6 or more inches, and for the first time in your life you're loading your body weight onto the inside of your femur down your leg. And with that, you've given up some bone, and you're loading the bone that you have left abnormally, so it adapts. Some of the bone in the upper femur then melts away. It takes about 5 or 6 years to melt away, and the bone near the tip of the stem farther down your leg thickens in response to these unaccustomed stresses. And that is really the reason why, if you ever have to change your stem, your doctor's looking at just an eggshell up top and the thick bones down in the distance, so we need even longer stems when we redo a failed total hip stem. Compared to a resurfacing, where all you've done is put a cap on the top, the upper femur stays strong, and so if by some chance you need that changed out in the future, then in the future you can have that first cut made across your upper femur and have the benefit of a primary shorter length total hip stem instead of one of these long stems that don't work so well. The other advantages besides saving bone and the fact that it's very easy to revise if there's ever a problem are the two most common complaints of hip replacement are to do with dislocations, which is when the ball pops out of the socket. And that's extremely rare with resurfacing. I haven't had any, and a lot of people I speak to have never had any dislocations with resurfacing. And it's because the ball is so large. It's not larger than yours, it's the same as yours, but it's large enough that it takes way more to get it out than the smaller balls associated with hip replacement. And it turns out that if you look at all the causes of redos of hip replacement, recurrent dislocations is the most common cause in most studies. It doesn't happen with resurfacing. That's a huge advantage. The second most common complaint with hip replacement is the doctor got my leg lengths wrong. One's too long, one's too short. And it's not that we're idiots. We know what we're doing, but because of the risk of dislocations, we often have to add a little bit of length so that it snaps in with a bit of tightness and therefore is harder to snap out. So those are big advantages. You don't have to worry about dislocations. That means in my practice with the anterolateral approach, we have no hip precautions, if you know what that means. That means that right after surgery you can bend up, curl up in a ball, reach down and touch your toes. You don't have to get a raised toilet seat. You don't have to worry about crossing your legs or lying on either side. It just becomes much easier to deal with. You don't have to worry about dislocations. The rehab is easier and quicker. And as far as leg lengths, obviously it's nice not to have unequal leg lengths. And there's more. The fact that you're loading your bone normally and all the nerve pathways that you've had your whole life, when you walk on a slippery set of stairs or down a muddy hill or something, you need balance. And we have evidence that balance is better preserved with resurfacing. In fact, professional athletes who have resurfacing can get back to their job. And you probably all have heard of professional athletes with hip replacements that don't necessarily get back to the levels they were at the beginning. Lots of reasons. If you're active, there's lots of reasons to consider resurfacing.
We have been inundated with ads and articles about the ASR recall and the problems. Would you discuss that for patients?
Sure, I can discuss that. I'll start by saying I'm a practicing surgeon. I'm not an engineer. I'm not a designer. I'm certainly not a marketing type of person. And I have nothing but respect for Johnson & Johnson DePuy Orthopedics. They have a wonderful company and great products. But I have looked at this. I've looked at this with a lot of interest of my own and for patients. I've learned quite a bit about it that I would like to explain. And it seems that when you look at it, there's quite a few differences between the ASR and other devices, and these differences are significant. So I'll tell you what my take on it is, bearing in mind that, again, I'm not a metallurgist or an engineer, but I'll tell you what I know at the moment. One of the first categories of difference between the ASR and the BHR, which is really all I'm going to talk about is the BHR, is the metallurgy. Almost all devices besides the BHR that are used in hip resurfacing are what they call heat treated. And there's various reasons why companies heat treat the metal, from limiting the scrap rate to getting the polish easier, or to apply a porous coating to the back of the socket. There's all these reasons why companies heat treat their products, but the BHR is not heat treated. And just to explain what I mean by that, if you have a mold and you're going to make a resurfacing device, it's cast cobalt chrome. So you melt this alloy of cobalt chrome molybdenum, you pour it into a mold, that's your casting. And in the case of the BHR, it cools down, and that's about it. They polish it, they spray some hydroxyapatite on the back of the socket, but they never reheat it. Whereas generally almost all other companies will reheat it for some purpose, and most often that purpose is to put the porous coating on the back of the socket. In the BHR's case, that porous coating is part of the original casting, so it doesn't have to be added later, and that has the added advantage that the beads can't fall off and get trapped in the bearing. And the beads generally in the other devices, including the ASR, are not cobalt chrome. They would be titanium, which is more typical in the industry for a porous coating. Now, doesn't sound like a lot, but heat treatment can have an effect on the microstructure of the metal. And the microstructure might have an effect on the wear properties. And this is what I mean by that. Cobalt chrome, high carbon cobalt chrome, is very, very good for wear. And much of the wear resistance comes from the carbides that are inside it. The carbides are almost like impurities in the metal. They are crystals between carbon and cobalt, carbon and chromium, carbon and aluminum. They're carbon crystals, and if any of you are married and you've bought diamonds or wear a diamond, you know that carbon crystals are extremely hard. And in the case of a cobalt chrome alloy, they're about twice as hard as the metal. So the metal alone might be hard, but these carbides are twice as hard. When you reheat the metal for any purpose at all, whether it's any of those things I talked about, like applying a porous coating or polishing or whatever, the carbides remelt into the metal. It's like if you put a sugar cube into a cup of tea. You can still see it in the bottom of the cup, but it's kind of crumbling, it's kind of dispersing. That's exactly what happens to the carbides. And in their crumbled, weakened state, they don't offer as much hardness and resistance to wear. And this is not purely conjecture, this is actually shown in wear simulator studies, but you have to do the wear simulator studies just right. In other words, you have to do it in a physiological way with a start and a stop and at a given speed that's physiological, because if you run a hip simulator in a lab at a relatively high speed for a long time without stopping, in a lubricated state there isn't any contact between the metals, so you might hide differences between heat-treated and non-heat-treated metals. But as I said, there's data, and it's recent data from earlier this year, that shows quite a difference between heat-treated and non-heat-treated devices. And it's a long-winded way of getting around to what your question was. The ASR was heat-treated, but then again, so are most of the others, so that can't be all of the explanation. So there's more. Resurfacing sockets are not like total hip sockets. They're just not. They are shaped differently by engineers who were smart enough to realize that in a resurfacing socket you still have the big fat neck of the bony femur that was going to bump into the edge. So in order to avoid that impingement and get more range of motion, the designers of resurfacing sockets used their geometry to push the head out a bit. So the head is in contact with metal, but it's pushed out. And that gains you more range of motion before impingement, less dislocations too, but it decreases the coverage of the ball by the socket. So the contact area is less. And as you know from wearing high heels on linoleum floors, high stresses on small areas can leave dents, and is obviously not ideal. The best case would be a broad area of coverage and lots of contact to spread the stresses out. Now, virtually all resurfacing sockets push the head out a little bit, but it turns out that particularly in the smaller sizes, the ASR pushed it out more than others. So in that way, it gives us an inkling of one thing that might be different about the ASR. The other thing that the ASR had different about it, and this really was different from the others, was its clearance. Clearance is the gap between the ball and the socket. You need a gap. You need a gap to get fluid in, because if this thing runs dry all the time, it really doesn't have very good wear properties. It works best like an engine with lubrication. The lubrication in the human is, of course, your joint fluid, which is a very, very good lubricant. And you need a little gap between the ball and the socket to suck that fluid in. According to fluid theory and lubrication and friction and all that stuff that I'm not, an expert in, the theory is that if you drop the clearance, it should do a better job of sucking fluid in, like capillary movement, capillary suction, osmosis, or whatever. It pulls that fluid in better. And that is true. If you're in a lab and you got your parts on a bench or in a machine, it is true. The problem could be, though, that when you insert these things into someone's pelvis, especially these young active patients with strong bone, your perfectly round socket slightly deforms. It becomes slightly oval. And if that deformation is in the same magnitude as the very small clearance, you can imagine a situation where the clearance would actually be used up by the deformation, and then it would start binding around the edges. And there is evidence, again, lab evidence, that if you deform a socket, the friction goes way up. There's no surprise there. But the BHR and the others, basically most of the others, have double the clearance that an ASR had. So if the ASR had 100 microns of clearance and it deforms close to 100 microns, that starts interfering with the lubrication and maybe binding. And the BHR and others have 200 or more microns of clearance. And so if you deform that around 100 microns, you still have plenty of clearance. So there's a difference there. And that low clearance, in fact, the BHR folks were influenced by this whole idea that low clearance might be better. And so they ran a few, actually implanted a few low clearance devices, and they didn't do as well as the high clearance or the more standard clearance BHR, so they abandoned doing that. So I think that's a significant difference between those. The ASR just had lower clearance, and perhaps, especially in hard bone, it deformed. Then there's the manufacturing tolerances. All of them have been looked at, of course, all the different brands of resurfacing, and it's true, the BHR is the roundest, and if you've got a ball in a socket and you want to limit wear, clearly round is good. The rounder the better. And in this regard, the ASR was not an outlier. Many of the others are in fact worse than the ASR at being round. So that can't totally explain it, but it does lead you to think that in an accumulation of differences, the ASR was just sufficiently different in enough different areas that it could have made a difference. And we know it made a difference because it in fact did have a unexpectedly high failure rate. Even at that, though, they certainly didn't all fail. Not even most of them failed. Most of them are still fine. But enough of them failed to alert us doctors that there might be a problem. And the company did the right thing by taking it off the market until this could all be figured out. The clinical results, I guess the proof is in the pudding. The best place to look if you're interested in results is the Australian National Joint Registry, which is publicly available on the internet, and you can look it up and see the results out to 10 years of different. Now, not all of the devices have been available for 10 years. The BHR is actually out to 14 years. But you can see there's just results are all over the map, and in general the BHR has the best results, the biggest numbers, the longest follow-up, and I continue to have confidence in it and use it, and I wouldn't consider the recall of the ASR to be a general slap on all metal or all resurfacing, and in fact not even on all ASRs, which, as I said, many of them are functioning fine.
When a patient talks to you and they ask about possible problems, for instance, revisions, infection rate, metal allergies, high metal ions, what do you tell them about possible problems with those?
Well, the complications are a bit different with hip replacement and hip resurfacing. There's common complications like infections and blood clots. I must say I've noticed less infections. For instance, I've had one in 1,000, so that's not bad. Less blood clots. There's less pain because you're not getting that root canal done of your upper leg. As far as metal ions, that's got its pluses and minuses. It's the first bearing we've ever had that we actually can do a blood test and see how your bearing is functioning. It gives us a chance at an early warning if there's a problem with the bearing, and I'm not by any means suggesting that everybody should go out and get their metal ions tested, but if you have pain and you're thinking there's something might be wrong with your artificial hip, whether it's a metal-on-metal total hip or a metal-on-metal resurfacing, you can have blood tests done, and then you can have some kind of imaging study, whether it's an MRI or an ultrasound, looking for these things called pseudotumors. As it turns out, pseudotumors are rather uncommon, They happen with every device, and even in Mr. McMinn's hands, who's an expert in Birmingham hip resurfacing, he's estimating that there's about 1 or 2 per 1,000 of his cases that would develop a pseudo-tumor, and that large Canadian study of academic centers had the same. And so it seems that it's there, these pseudo-tumors, but it's a low risk. And as we learn more about it, I think it's not so much a random event or a mysterious event. The formation of a pseudo-tumor has been pretty well studied, and it has a lot to do with accurate cup position. This whole concept of edge loading is something that I'd like to just briefly mention. In the normal resurfacing, put in correctly, there's a little wear patch, and the wear patch, as the ball rubs against the socket, is relatively small, and it's in the dome, surrounded by metal, and therefore lubricated by the fluid all the time. But for reasons of design or poor surgical technique, if the cup is put in, say, too vertical or facing too much frontwards or backwards, this wear patch can find its way to the edge, and this is called edge loading or edge wear. And at that point, the wear patch, where the metal rubs together, is no longer effectively lubricated. And without exception, all of the pseudo-tumor retrievals, the implant retrievals that have been examined, had edge wear, and they had higher wear than other devices that were retrieved for other reasons, like infections or fractures or things. So it seems clear to me that pseudo-tumors aren't, as I said, a mystery or an allergy or some unpredictable event. They occur because of edge loading. That may be a patient issue, because some patients have a certain twist in their upper femur. It may be an implant issue, and as I showed earlier, the ASR, which was forced outwards a little bit more than the others, may have experienced more edge loading than others. And it may be simple bad surgery that put it in wrong, or could have been better. And those cases that develop pseudo-tumors can be problems. You can have damage to your tissues, pain, so it needs to be taken out if that happens and changed to some other bearing. Probably metal on plastic would be the best choice at that point. Metal ion levels, you know, this is not lead or mercury or arsenic. Cobalt and chrome, oddly enough, you already have them in your body. I have them in my body. No one's put an artificial joint in me. Cobalt is part of vitamin B12. You have it. Chromium is needed for your insulin to work, and you have that too. You can buy it in a health food store. Even molybdenum is in your body as an enzyme cofactor. So the amounts that you have in your body are very small, okay? Something under a half a part per billion. And after you get a BHR done, the level will rise. It'll double, or maybe quadruple. It might go up to 2 parts per billion. And that's okay. We have 30 plus years of data on metal total hips with exactly this metallurgy, showing no change in the cancer risk, actually an increase in life expectancy, another study that showed a decrease in the cancer risk. So the BHR has been around long enough too that with 125,000 of them in, I think we'd know if it was killing people and causing cancer. The problem is if you have edge wear or some altered, I don't know, wear state where it's either the wrong device or it's loose or it's put in badly, then you have these high levels of ions. And the Brits came out with a number of 7. The US FDA hasn't come out with any magic number that you should get worried at. But you can find really high levels, and not just with hip resurfacing, by the way, but with hip replacements that are metal on plastic. You can have very high levels of metal, because all these devices have metal in them, and some of them can be bad or corroding. So talk to your doctor if you have pain, or if you have concerns, or if you have an ASR, or if it doesn't seem to be put in straight. you can get your blood tested for cobalt and chromium. It has to be done in a special way with special tubes and special needles, so no contamination. You gotta stop taking your drugstore chromium before you get this test, and have it tested. And you can be reassured if the level is, let's say, under 7, or most likely with a BHR it'll be between, I don't know, 1 to 3 parts per billion, and that's fine. Sure, it's high compared to a normal person who never had surgery, but it's not a problem. We know that from 30 years of careful follow-up with these people.
So, just as a summary, where do you think hip resurfacing will be going in the future?
I think the effect of the ASR recall has been to give surgeons pause. And for instance, me, I've looked at this a lot now, trying to understand whether these bad results with the ASR could be translated to what I'm doing with the BHR. And honestly, my conclusion is no. I think the BHR is quite different. It's got a lot more data behind it, and the data has been really good. Where there are failures, we understand the reason, and it's very often the surgical technique. And so, as that gets out, you will probably see that doctors who were doing 1 or 2 of these a year, or 10 a year, or some relatively small number of resurfacings, will refer the resurfacing patients on to other doctors who do them so routinely that they're less likely to have, I don't know, a bad day, or put it in wrong, or do something that will affect the outcome. And you know, I think it's a finicky enough procedure, difficult to do. It's difficult to get exposure with the head still in the way when you're trying to work on the socket, that it probably should be done by people who subspecialize in that. It's not that anyone's going to make rules and say you can't do these if you don't do a lot of them, but I think common sense is that these are difficult operations that have the potential to cause trouble. You ought to probably think twice before you do 1 or 2 a year. Now, we're training people all the time, right? I mean, I'm in a teaching hospital, I'm training residents how to do it, and other doctors that come to visit, they're learning how to do it, and you know, some of them look at it and they say, yeah, I think I can do that and get interested in that. And it's, well, and there's others that decide they're not going to do that, and that's probably for the good. And your website is actually really valuable, because patients who don't know any better can log on and see who has experience. And while doctors have to get experience somewhere, if you're looking after yourself, you really want to go somewhere where they've done it before, done a lot of them.
Well, thank you very much. You've educated us, and I know a lot of prospective patients will learn a lot. Thank you.
Oh, my pleasure, and thank you.